UKMLA Infections and Infectious Diseases, where we go through high yield infections by body system. So we've done session one and two already, and this is our third and final session, and we're covering skin and soft tissue infections, a brief few slides on MSK infections, tropical medicine, and then high yield antimicrobials. So if we start with Archie, if you just want to share your slides and we'll get started. Again, I'll make sure to pop the feedback form in the comments. So if people need to leave early, as long as you fill in the feedback form, I can send you the slides. And again, if anyone's got any questions at all, then please pop them in the chat and we'll try to answer them.
Hi everyone, I'm just going to start with the skin and soft tissue infections. This will be a very interactive session, hopefully. So if you can just, be interactive in the chat and just give the answers to the questions if you can. So the first question, we'll start with the question and then we'll go over sort of the theory behind it. I'll give you a few seconds, 30 seconds to go through this, and maybe if you can just pop the answers in the chat.
Archie, I don't know if you can see the chat, but we've got some answers.
Oh, have we? Sorry.
So we've got B for corneal ulceration.
Okay. So what do you guys think this is? Let's start with what this looks like. It's an intensely painful eruption around the right eye, and she has no significant medical history. As you can see, the rash is quite vesicular. So we're thinking of herpes because herpes is painful and it's also a very vesicular rash. And usually herpes won't be a single isolated lesion, it'll be multiple small lesions. So if you're thinking of herpes in this case, yes, corneal ulceration can be a potential complication, but hopefully if it's treated properly, the most likely long-term outcome is that it's not going to have any long-term impact and it will completely resolve as long as you give the patient acyclovir. And this is just a question from the MSc paper that's there on OneMed. So it's from the UKMLA content map. So it's a good idea to be aware of some of the common viruses and the bacteria. And then while we're talking about herpes zoster ophthalmicus, we'll talk about eczema herpeticum as well, because again, it's caused by the same sort of species of the virus. So herpes can commonly be caused by HSV1 or 2. And eczema herpeticum, as the name suggests, normally would have a previous medical history of eczema in the patient. And again, because it's herpes, it's going to be quite a painful rash. It'll be a vesicular rash as well. And in your exam, if you see something like monomorphic punched out erosions or circular ulcerated lesions, then you ideally want to start thinking about something herpeticus. And it is potentially life-threatening. So if you suspect this in a child, then you want to admit them immediately for IV acyclovir. And in the exam, I think on QuesMed, there are some questions where they try to catch you out by giving IV acyclovir and oral acyclovir as an option. So remember, life-threatening, you want to give it IV. Next question. I'll give you guys a few seconds to go through this as well. Let's put a timer on. Oh, sorry, I've just seen the chat. Time to read the explanation for it. Yes, I'll keep the slides a bit longer. Perfect. We've got some answers. This is molluscum. This is the justification. So these lesions, like it's a, sorry, just give me 1 second.
So when we boil it? Yeah, we'll have a conversation. Oh, right. Yeah, that'll be more.
Sorry, I'm in Macclesfield right now, and the accommodation is a bit weird. But right, so the answer is molluscum, and these are usually painless lesions. And again, they're self-limiting. There's no treatment that you really need to give for them, but a lot of patients do benefit from reassurance and just having a diagnosis. And again, molluscum it's usually a pediatric condition where it affects smaller children. And like you saw in the previous picture, these were quite pinkish and quite pearly papules with central umbilication, which is, I guess, just a fancier word for there might be a central like spot that you can see. And like herpes, these appear in clusters, but they're not normally painful. So if you can see this picture, it's quite pearly, it's quite pink. It looks like it's vesicular filled with fluid, and then in the center you'll see an like a little ulceration or an umbilication. So that's molluscum contagiosum. Treatment, it's self-limiting, but then you have to tell them don't scratch the lesion. And if you do scratch the lesion, then you're introducing bacteria into it. And school exclusion is not necessary. If the patient has HIV or any lesions around the eye or anal genital lesions, that's when those are red flags, and then you would want to escalate that to your pediatric team. Moving on to the next question. Sorry, this is a bit fast paced just because we have a lot of content to go over. But if at any point you want me to slow down or go over something again, just put it in the chat and I'll take a look at that. Do you guys want to give this question a go? Okay, I'll just move on to the answer now. So the answer is C, when no action is necessary. And this is because the child is, sorry, just one sec. Oh, thank you so much. I'm so sorry. Oh, shit.
Hold on up. Yeah.
Right, sorry, I promised no more interruptions. The engineer was here, my heater wasn't working, and now he's sorted it out, thankfully. Right, so in this case, if I go back to the question, the newborn is clinically well, and even though the mother has the antibodies, it is likely that she has transferred this immunity to the child as well. So considering the fact that the child is well, and also it is very likely that he is already immune, we do not need to escalate. So you wouldn't do anything medically, but obviously you would safety net them and you would consider escalating if the child had any systematic symptoms or if he was unwell and had failure to thrive. So we'll just go a bit over chickenpox. It's caused by the VZV, varicella zoster virus, which, if you remember, it's sort of from the same family of the shingles virus as well. And it's spread via the respiratory route, which is why if a child has chickenpox, you usually isolate them until they're better. And initially, it starts with a prodrome of fever, and then after a few days, the itchy rash will start. So if they've started having a rash, that means that they've already begun or they've already reached the infective phase. And then the rash itself, initially it's very flat, it's very macular, and then it becomes a bit coarse and rough papular, and then it starts forming vesicles that ooze and scab. And management, I'm sure all of you know, for chickenpox is supportive. You can give them calamine lotion for the itching, but then you also have to make sure that they're not scratching it. And school exclusion is necessary until all the lesions are dry and have crusted over. And as you can see from the sign here, chickenpox is a notifiable disease. Some complications of chickenpox could be necrotizing fasciitis because of a secondary group A streptococcal infection. Chickenpox is a virus. Neck fascia is usually caused by bacterial infections that are more severe. But if you scratch and you're causing the entryway for more bacteria into the skin, it can lead to neck fascia. Pneumonia as well, encephalitis, and then disseminated hemorrhagic chickenpox. And very rarely you can see inflammation in other organs like your joints and your kidneys and your pancreas. Now, does anyone know what drug is contraindicated in chickenpox? I know this is a very vague question because so many drugs can be contraindicated. What's like a very famous drug that basically everyone just has all the time, which you can't have if you have chickenpox? Yeah. So NSAIDs, like you guys mentioned aspirin, they are contraindicated in chickenpox because they increase the risk of a secondary bacterial infection. So it's not just aspirin, it could also be the diclofenac, or what's the brufen that children have when they have a fever. So you need to counsel parents to not give them brufen, even though they might have a fever in chickenpox because it's contraindicated. Now, how do we go through chickenpox exposure? If you have someone who's been exposed to chickenpox, if they're immunocompromised patients or if they are pregnant patients, then we need to be proactive about that. And first, you're going to check if they have any immunity against that. So you're going to look for their varicella zoster immunoglobulin in their blood. And then if they don't have immunity, then you give them antivirals. Specifically in pregnancy, they've noticed that the outcomes are much better if you delay the antivirals to day 7, which is why you don't give them immediately. You give it to them after a week. However, if they are immunocompromised, you would give them the immunoglobulins. But in pregnancy, you would first check the maternal blood, and if they don't have the antibodies, or if the mother is systemically unwell, then you would give them acyclovir, but after day 7. If not just exposure, but you've got confirmed chickenpox, then IV acyclovir should be considered in everyone in newborns, in immunocompromised patients. And if they're pregnant, then you can consider oral acyclovir. I think you're less likely to give them IV acyclovir in pregnancy just because acyclovir is not a very good drug and it has a lot of side effects. So this would be a senior decision. But I think from an exam point of view, if you have the option between IV and oral, specifically for pregnancy, you'd go with the oral option. Moving on, what does this look like while we're talking about chickenpox and varicella? Yeah, perfect. It is shingles. So shingles is just a reactivation of the varicella zoster virus. In fact, your VZV is a very sneaky virus. It can live in your sort of nerves and the dorsal root ganglions. And as a result of that, it can reactivate after a while, after a few years. And that's why in shingles, because it usually stays within one dorsal root ganglion or within one nerve ganglion, when it reactivates, it'll show the symptoms in a dermatomal manner. And you will notice a similar rash to chickenpox where it's vesicular, quite itchy, quite painful as well. And again, it's initially macular and then it becomes vesicular. Like I mentioned, dermatomal distribution, the most common dermatomes are T1 and T2. And then for shingles, it's an emergency. So you would give them antivirals within 72 hours. And obviously analgesia because it is quite painful. This specifically from a PSA point of view, because there was a question in the mock PSA where, or was it in one of the papers, there was a question about this patient with shingles. And we're taught that for trigeminal neuralgia or post-hepatic pain, you'd give them amitriptyline, but the question was about acute pain and shingles. And even though amitriptyline would be managed if they have chronic pain from shingles, in the acute phase, you'd still give them things like IV paracetamol or ibuprofen. So in the PSA, if you have a patient who has the rash and the shingles is an acute infection, for pain relief, you'd give them paracetamol. But then if they say, oh, she had shingles 2 months ago, but she's still experiencing pain, then you would consider giving them amitriptyline. Does that make sense? And oral corticosteroids may be considered, but I'm not sure what the specific guidelines regarding them are. So I guess just remember the paracetamol and NSAIDs as first line for acute attack. Complications of shingles, postherpetic neuralgia, herpes zoster ophthalmicus, herpes zoster oticus, which if you remember, that's Ramsay-Hunt syndrome, where you have the rash that starts from the ear. And that's it about shingles. If you have any questions, please put them in the chat. I can't see any right now, so I'll just move on. Moving on to our other favorite viruses. So we've got measles, mumps, and rubella. And this is just a nice summary diagram of what they are. So can someone tell me what 1, 2, and 3 are? In what order have I put the diagrams? Which one is measles, which is mumps, which is rubella? Starting with the first one, rash that starts on the face, red eyes, and a bad cough. What is this most likely to be out of the 3 options? Okay. So we're getting some mixed answers. So this is measles, mumps, and rubella. And to be fair, we did get rubella as one of the answers, which would technically make perfect sense because rubella is just German measles. They're basically the same disease in a different font, so they can be quite confusing. But I guess with measles, you want to remember that the rash usually starts on the face, sometimes usually starts behind the ear, actually. And they also have prodromal symptoms like a cough, and then in their mouth, you'll see Koplik spots, which are white spots, whereas rubella is mainly just the rash without all the other extra stuff. Mumps, on the other hand, is quite different to both measles and rubella, where you've got just swelling everywhere. So you've got swelling about the jaw, you can get swelling in your testes, and also systemic symptoms like fever and coronal symptoms. So starting with measles, and these 3 are notifiable diseases as well. Interestingly, for chickenpox was notifiable, but shingles is not notifiable. So just keep that in mind. Right, so with measles, you usually start with a prodrome of fever, conjunctivitis, and then you can have white little spots in your mouth. And the rash usually comes on a few days after you've contracted the measles. Starts behind the ear. It is a maculopapular rash, so it's flat and raised at the same time. And then it can become quite blotchy and converge into each other. And then you also have desquamation that typically spares the palms and soles. And there's another condition not within the skin infection, but within children, which in which you normally have desquamation that occurs mainly in the palms and soles, like Kawasaki's or scarlet fever. So remember to separate those two. In measles, the palms and soles are not affected, when scarlet fever and Kawasaki's they are. And again, like I mentioned, measles is a notifiable disease. The most common complication of measles, does anyone know what this is? Can you put it in the chat? Does anyone know what the most common complication is? That's a good answer. Subacute something, scleritis something, and that's spot on. Where you've mentioned inflammation of some sort, which is correct. And the most common site of this inflammation is otitis media, which leads to infection. So the most common complication, especially in children, is otitis media. However, the most common cause of death in patients who have measles is actually pneumonia. So just be aware of that sneaky MCQ question in case it comes up. And in spite of all of this talk about how awful measles is, there is no treatment for it. Treatment is normally supportive. And for close contacts, if your child is not vaccinated, then the MMR vaccine should be given ideally within 72 hours. Moving on, the mumps, which we mentioned is just a bunch of swelling everywhere. So you'll have fever, muscular pain, malaise, and then you have parotitis, so swelling of the parotid gland. And this can usually present with symptoms like pain while they're chewing or an earache, and then orchitis as well. Transient hearing loss again, because the parotid gland is sort of right there where the ear is, and the cranial nerve 8 can be affected. And again, there's no treatment for mumps. It's supportive management, and hopefully it self-resolves. I don't know if you guys have watched Brooklyn Nine-Nine, but there was an episode where I think they both get mumps, and that was quite a funny episode. And that just helps me remember that with mumps, you just have swelling everywhere. Moving on, rubella, which is also known as German measles. You do have a low-grade fever, but rubella is just measles that doesn't look as bad. And again, you have a maculopapular rash where the rash starts on the face. Usually, I don't think in rubella the rash specifically starts behind the ears, but it is usually on the face as well, and it self-resolves. And then you can have lymphatic swelling as well. Rubella with pregnancy is a different thing. Even though rubella can be milder than measles, I think, as an infection, when it comes to pregnancy, congenital rubella syndrome is quite fatal, and it is quite sinister. So we'll just go through that quickly. The child can have sensorineural deafness, cataracts, heart disease, growth retardation, hepatosplenomegaly, purpuric skin lesions, salt and pepper chorioretinitis, microphthalmia, cerebral palsy. I don't know a good mnemonic to remember all of this, but just remember if there's an infant with lots and lots of different things going on with their eyes, with their ears, with their heart, and they've got a rash, then think of congenital rubella syndrome as a differential. If the mother is not already vaccinated, the mom should be offered the MMR vaccine after birth. However, if the mother is pregnant, do not vaccinate her, because the MMR vaccine is a live vaccine, and you do not give any live vaccines during pregnancy. Okay, moving on. What do we think of this? What disease is this, or what virus causes this disease? I'll give you guys a few seconds to answer in the chat. Yeah, perfect. Yes, it is slap cheek syndrome, and it is caused by parvovirus B19. It's also called fifth disease. And it's also known as erythema infectiosum. Now, the rash may spread to the rest of the body, so it's not necessary that it's localized to the face. And if it occurs in adults, it may also cause inflammation in the joints. However, it is a self-limiting disease. And then in pregnant women, especially in the first trimester and the first 2 trimesters, when the baby is still being formed, where the organ systems are being formed, and there's a high risk of complications, parvovirus B19 can cause hydrops fetalis. And if you guys remember the list of infections that are quite harmful in pregnancy, parvovirus is on that list as well. And in patients who have sickle cell anemia, it can precipitate an aplastic crisis as well, which is also a very FastMed favorite question for some reason. And then in immunosuppressed patients, again, it can cause pancytopenia, similar to the aplastic crisis in sickle cell patients. Okay, let's do a question now. I'll give you guys 30 seconds to go through this. Any answers, guys? What do we think? Yeah, so we've got answers, EBV serology. Perfect. This is Epstein-Barr virus, which causes glandular fever, or the kissing's disease, as is known in America. And usually when you have a younger adult with a sore throat and a fever, and also has lymphadenopathy and maybe a rash as well, you want to think of glandular fever. And the reason why we're discussing this within skin conditions, even though it may not always be associated with a rash, is because sometimes EBV may be misdiagnosed as a strep infection, and then they're prescribed antibiotics for it. And one notable thing that happens with EBV is that after you give them amoxicillin or any kind of antibiotics, they get a widespread maculopapular rash. And that's not an allergic reaction to the antibiotic. It's just the way EBV is, the virus reacting to the antibiotic. So yeah, diagnosis is monospot test, and then treatment is again supportive, and you'd advise them to avoid contact sports for 4 weeks because of the risk of splenic rupture. Okay, moving on to the next question. We'll try to do this a bit faster because we've now started with the bacteria, and there's quite a few bacteria that we need to be aware of. So I'll give you guys another 30 seconds. So this patient is receiving chemotherapy. So he's already probably immunocompromised and has cancer. And his Hickman line is red and tender. So we're thinking of that as the port of the site of infection. What do you guys think the likely pathogen may be? No takers, that's fine. Yeah, perfect. Staph aureus. So strep. Okay. In the justification for the answer, they've only focused sort of on the gram-positive cocci part, where with streptococcus, they're mostly in a chain. Staph aureus causes line infections. What we need to remember is that if you hear of line infections, for example, through a catheter, through a central venous line, through an arterial line, it is most likely going to be Staph aureus unless they have other very obvious pointers towards something else. So if you think of line infections or any external skin barrier is broken down and then they have an infection, for example, a cellulitis, then you're going to first think of Staphylococcus, irrespective of whether you know the gram staining mentioned in the question or not. And Staphylococcus is it does cause quite a lot of primary infections. So it causes cellulitis, it can cause central line infections, infective endocarditis can also be caused by staph, even though it's not the first. And then osteomyelitis is a very important infection that you need to remember that Staphylococcus also causes. Because usually when we think of staph, we think of cellulitis, flucloxacillin. But we also need to be aware that it can go down into the bone and eat away at the bone. However, if you have a patient who has sickle cell disease and they present with osteomyelitis, the first thing you want to think about is Salmonella rather than Staphylococcus as the causative bacterium. And then staph can also cause toxic shock syndrome or staph scalded skin syndrome, which, if you remember, are the conditions with Nikolsky sign positive, where your skin literally just peels off. And then the very popular hospital infection, MRSA, is also Staphylococcus methicillin resistant Staph aureus. And for MRSA, because it's resistant to your penicillins, you'd give them vancomycin, teicoplanin, and also isolate the patient. So remember, cellulitis, osteomyelitis caused by Staphylococcus, you'd give them flucloxacillin. And then remember, if they have sickle cell and presenting with osteomyelitis, it's Salmonella rather than staph. and impetigo is an important, it's a form of cellulitis, but it's an important thing to remember with staph. Speaking of Nikolsky sign, I've already gone over this in the previous slide, so I'm not going to open the floor to you guys to answer this. This is staph scalded skin syndrome, where you can see that the skin is sort of desquamating and peeling off. What do you guys think is happening here? You just want to quickly type in the chat. DVT, that's a very good thought. But what infection-related thing are you seeing here, considering that it's an infectious disease? Yeah, cellulitis, perfect. And the reason why you can tell it's cellulitis is because this leg is quite swollen. You can see there's a difference in the diameter. It's quite erythematous as well. So you'd think of DVT as a very do not miss important differential, but in the context of skin infection with cellulitis. Okay, I'll give you guys 30 seconds to do this question. Rash on his face, mainly around the chin. And it started with a blister that ruptured, and now there's a yellow crusted lesion that has since enlarged. And he's a primary school teacher as well. What do you guys think is going on here? Yeah, perfect. Impetigo. So again, caused by Staphylococcus aureus, like we discussed previously. You guys can read this later when I send out the slides. But going through impetigo, the reason why that question is important because this man is 42 years old, and usually you associate impetigo with childhood infections, but adults can also get it as a primary infection. So you'll find gold encrusted skin lesions. With regards to children specifically, they should be excluded from school until all the lesions have crusted over. Or if you're giving them antibiotics, you can exclude them until 48 hours after they've started the antibiotics. If it's a limited localized disease, you don't need to necessarily give them antibiotics. You can trial with hydrogen peroxide cream. However, if needed, you can prescribe first topical antibiotics, and then if it's extensive disease, you'd give them oral flucloxacillin. If they're penicillin allergic, oral erythromycin. Moving on. Also, all these antibiotics, I know you usually rely on trust guidelines I would use the trust guidelines to give the suitable antibiotic. But I think for certain skin infections, it's good to just keep them in the back of your head because they might come up as an SD on the EKT. Okay, next question, 30 seconds. She's a 3-year-old girl who had a fever and a runny nose. Temperature is really high. What else is high? Her respirator is high. She has a red throat, looks flushed with a flat erythematous rash across her trunk, and it feels rough. So yes, like you guys have mentioned, it's scarlet fever. In scarlet fever, you normally have a sandpaper rash, which feels very rough. An important differential for scarlet fever is actually Kawasaki's disease, which you should not miss. Again, like it's mentioned here, it usually presents with other symptoms like conjunctivitis, swollen lymph nodes, etc. And also the fever typically lasts for longer than 5 days in Kawasaki's. So scarlet fever, we've talked about staphylococcus. Now we're moving on to streptococcus, which is also a very important bacteria. And scarlet fever is caused by group A hemolytic streptococcus. It's common in younger children, and you diagnose it by doing a throat swab. However, you're not going to wait for the results to start your antibiotics. You'd give them oral Pen-V. Again, you can give them macrolide if they're allergic. And then with scarlet fever, once they start antibiotics, they can go back to school within 24 hours, which is not the same as if they have a staphylococcal infection like impetigo, you have to wait 48 hours. These are just some of the symptoms that you can see with scarlet fever. But remember, if they describe the rash as quite rough and sandpaper-like, along with strawberry tongue, sore throat, you're going to think of scarlet fever. And desquamation occurs later in the course of the illness. And remember, it usually occurs in the palms and the soles of the feet. Next question. This is quite a long question, but I'll give you guys a few seconds. So we have a 44-year-old man with 3-hour history of perineal and testicular pain, redness, and rash. Sudden onset, severe pain that's worst over the rash site with reduced sensation to the surrounding skin. His obs are fine. And then the rash has spread within the last 30 minutes. Cremasteric reflex is present. Both the testes are fine, equal height. And he has a past medical history of type 2 diabetes, for which he takes an SGLT2 inhibitor. What do you guys think is going on here? Yeah, Fournier's gangrene, perfect, which is a type of necrotizing fasciitis. So if you have acute onset, very, very severe pain, very severe symptoms, and progressing very rapidly, especially in a patient with risk factors, for him, it was the diabetes and the fact that he was on an SGLT2 inhibitor, you're going to think of necrotizing fasciitis until proven otherwise. It's a medical emergency. You're going to call everyone you can. And it's usually there's different types of it. But it's important to remember that, yes, most commonly it can be caused by streptococcus, but staphylococcus can also cause neck fash. And the most common affected site is the perineum, so Fournier's gangrene. And these are just some beautiful pictures to scare you guys. Risk factors, obviously, if they have skin trauma, if they have type 2 diabetes mellitus, especially SGLT2 inhibitors, because it's literally making you pee out sugar. So bacteria are going to grow there. If they're IV drug users, immunosuppressed, etc. Skin necrosis, sometimes you can have gas gangrene as a later sign. And if you have gas gangrene, you're going to think of Clostridium, because Clostridium usually produces a lot of gas. So if you have a patient with query neck fash with some crepitus and like a vesicular rash, instead of thinking about streptococcus, think about Clostridium. And fever and tachycardia may be absent, like we saw in the previous case where his obs were normal. And then treatment is urgent surgical referral and IV antibiotics. Okay, next question. We'll run through this because I feel like I've gone way over time. What do you guys think is going on here? We have a target lesion. And then this patient is a hiker as well. So we're going to think of Lyme disease, which is caused by Borrelia, the bacterium Borrelia. And the mode of transmission is tick bites, which are normally found in nature. Early features would be your erythema migrans, your bullseye rash, and then late features would be things like cardiovascular disease, neurological problems, etc. If you have erythema, if you have the rash, then you can diagnose it clinically. If not, if the rash is not there, then you can use ELISA. And if it's positive, then you do an immunoblot test. Even if it's negative, you'd still do an immunoblot test. So you do an ELISA and an immunoblot test to diagnose Lyme disease. And if the first set of bloods were negative, then you'd redo them again after a few weeks. Yes. Management, conservative. If you can still see the tick, then remove the tick, obviously. If there are symptoms present or if the rash is present, then you'd give them doxycycline for 21 days, which is quite a long dose of doxycycline. If doxy is contraindicated, for example, in pregnancy, you'd give them amoxicillin, which is interesting because normally in pregnancy, the only antibiotic you think of giving is erythromycin. In Lyme disease, you give them amoxicillin because it's quite a severe infection with a lot of negative sequelae. If the disease is disseminated, you're going to give them ceftriaxone. And by disseminated, I mean if they have signs of heart disease or if they have signs of meningism as well. Okay, we're going to quickly wrap up. Human and animal bites. If a human bites you, if an animal bites you, you'd give co-amoxiclav. If penicillin allergic, you'd give them doxycycline and metronidazole. It's just to make sure you're covering a huge spectrum of gram-negative and gram-positive. For human bites, also consider testing them for hepatitis C and for HIV as well. Fungal skin infections, this is just a quick overview of them. So your tinea infections can be basically anywhere on your body. You can have tinea capitis on the skull, you can have tinea corporis, you can have tinea pedis, etc. This is just your ringworm, which causes the annular lesion, where it's a ring-like lesion with central sparing. And then you'd give them topical antifungals like fluconazole. Athlete's foot is also a type of dermatophyte infection. Pityriasis versicolor is caused by Malassezia furfur, which is when you have hyper or hyposegmented patches of skin. There's no treatment indicated for this. It's quite conservative and self-limiting. Some important parasitic skin infections, scabies, which is a very, very disgusting condition because it's very itchy. Symptoms, it does have a very long incubation period. And in an SPA context, they might mention things like linear burrows, usually on the side of your fingers, and you'd give them antiparasitic medications like Malathion or permethrin for the patient and for all household contacts as well. Head lice, another very itchy condition. First line would be wet combing and Malathion. Household contacts for head lice do not need to be treated unless they have symptoms. And then another important parasitic skin infection is threadworms, especially in children if they have very itching at night or if they're very distressed during nighttime, and then you see worms coming out when you change their diaper. That's threadworms. And then you'd give them oral mebendazole for the child and for all household contacts as well, because it's very infective. This is just a picture of scabies. As you can see, there's like linear, I mean, it's meant to be linear burrows, which I think I might be a bit blind because I can't see them, but it's just a picture of scabies. School exclusion, we'll just revise this quickly. For scarlet fever, 24 hours. Whereas if you have whooping cough or if you have impetigo, it's 48 hours after you start antibiotics. Measles, 4 days from the onset of rash. Rubella, 5 days from the onset of rash. And mumps is also 5 days from the onset of swollen glands. Chickenpox, you exclude them completely until all the lesions have crusted over. And scabies, until they're treated, you keep them at home. Notifiable diseases, recap, scarlet fever, leprosy, neck rash, anthrax is an urgent. If you suspect anthrax in a patient, you should be locking the hospital down. Chickenpox, routine. Measles is an urgent referral. Rubella is routine. Mumps is routine as well. So remember, neck rash and measles, you would urgently. Oh, right, sorry. Pityriasis versicolor is treated with antifungal shampoos. That is correct. It is treated with antifungal shampoos like ketoconazole. Anyway, sorry if that was a bit rushed. Are there any questions? Just hold for a few seconds in case there are.
Okay, I think that was really good. Thank you, Archie. So I can't see any questions in the chat, so I'll move on. So I'll just share my screen.
Sorry, I just wanted to show the slide because I think I skipped over it, but it's just a summary of all the skin infections from bacterial, viral, and parasitic point of view. So when you get the slides, you can go through it. Yeah, thank you.
Okay, can everyone see this? Yep.
It's not in presenter mode yet. Oh wait, no, you are. You're sorted.
So there's only 2 slides on MSK infections. So we're going to start with osteomyelitis. So this is essentially inflammation of bone and bone marrow, and it's usually caused by bacterial infection. And the most common cause is a Staph aureus. So features, patients will have fever, pain, tenderness, erythema, and swelling. And they'll also have present risk factors. So a lot of the time you'll see patients might have had open fractures, they might have had recent surgery and have a prosthetic joint. Osteomyelitis is seen quite a lot in patients with diabetes, diabetic foot ulcers, and patients are immunocompromised. Again, peripheral arterial disease, because essentially the bone is not getting an adequate blood supply, so is at risk of necrosis and things like that. Also intravenous drug use, and again, immunosuppression. So does anyone know what the gold standard investigation is for osteomyelitis? It's quite I feel like quite a common exam question. And I can't see the chat, so if anyone can let me know. Okay, so it is an MRI. And also if you do bloods, you'll have a raised white cell count, raised CRP, ESR, and also blood cultures that might be positive for a causative organism. So to manage osteomyelitis, is surgical debridement. In acute infection, you give 6 weeks of flu clox. You can also add rifampicin or fusidic acid for the first 2 weeks, and you give clindamycin in pen allergy. Like Archie said, for MRSA infections, vancomycin is good, and you can also give tigeplanin as well. If the patient has chronic osteomyelitis, you extend the course of antibiotics, and usually this is around 3 months. If the patient has osteomyelitis associated with any prosthetic joint, a lot of the time the patient will need a complete joint replacement as well. Okay, so the second MSK infection and final one we'll talk about is septic arthritis. So the most common cause of this is Staph aureus. In young sexually active adults, the most common cause is Neisseria gonorrhea. You can also get Haemophilus influenzae and group A strep as a cause, and also E. coli. I do think this is quite high yield, so just remember Staph aureus and especially gonorrhea in a young sexually active adult. So clinical features, acute swollen joint and restricted movement, warmth to touch, fluctuant, fever. So you want to do synovial fluid sampling. Ideally, you want to do this before starting antibiotics so it doesn't affect any culture. You also want to do gram staining, crystal microscopy, culture antibiotic sensitivities. And I think, especially in an exam, always remember the differentials for septic arthritis because patients can present quite similarly. So we have gout, pseudogout, reactive arthritis, and hemoarthritis. So I think for your exams, go through these conditions and sort of just remember how you differentiate between them. So, for example, in gout, you get the negative bifringent needles. In a pseudogout, you'll get the positive bifringent rhomboid crystals. With reactive arthritis, you get the sort of the Rater's triad of can't see where you'll climb a tree. So the conjunctivitis, urethritis, and joint pain. And then if the patient has hemoarthritis, they might have had a preceding trauma, and they'll have blood in the joint space. Okay, and then to manage a septic arthritis, so you always want to give empirical IV antibiotics before you know the sensitivities, but again, ideally sample the fluid before or aspirate the joint before you give antibiotics. Sometimes it's not possible to do this though. So you give 4 to 6 weeks of antibiotics. So first line is flucloxacillin, and then clindamycin if the patient's pen allergic. Again, vancomycin if you suspect MRSA, and then ceftriaxone in Neisseria gonorrhea. So a very quick summary of the 2 most common MSK infections you might see in exams. So that's everything from me. Okay, so if we want to move on to tropical infections now, Caben.
Yeah, sure. Just let me know if it's sharing.
Yep, it's shared.
Cool. Okay. So yeah, my name is Caben. I am an intercalating medical student, so I've done 4th year and I'm intercalating. So a lot of what I do nowadays is infections, and luckily it's around tropical stuff. So it's stuff that I'm interested in and I find interesting. In reality, in your exams, they're unlikely to assess you on much tropical medicine, which I think is unfortunate. You might not. And if they do, it's probably going to be on malaria. So I think the most useful thing that I can probably teach you today is how to take an effective history in a returning traveler, but then we'll go over all the other content that I think is useful. Okay, so this is going to be your presenting complaint. So we've got a 22-year-old student who has come back after an elective to South Asia and developed some fever. Okay, this is what they're like normally, and this is what they're like now. So the more attentive of you might notice they're not feeling up to scratch just at the moment. So let's think about what kind of history questions we could be taking. And rather than the generic history ones, which you all know how to take, what things could you ask specifically for a returning traveler? I can't see the chat at all, so if someone can shout out if people are saying things.
So we have what they ate, details of where they went exactly, what they ate, what they drank, if they
Cool.
had ice, if they were in water. So really good answers.
Yeah, excellent. This is essentially my checklist of what you should be asking. So yeah, big things are where they stayed, what they ate, where they ate it, what they drank, was it bottled or tap? Ice in drinks is really important. Oftentimes ice will come from tap water. In terms of like swimming, generally fresh water is a bit worse than seawater. You can get some pretty severe infections like schistosomiasis. Specifically for that, what happens is if you're swimming in fresh water where the schistosoma larvae are present, they can basically bore into your skin, mate somewhere in your like blood vessels near your intestines or your bladder, and then produce eggs. In the future, that gives you an increased risk of like bladder cancer, but it can also cause liver problems if those eggs travel up to your liver or to different organs. Walking barefoot is a risk for parasitic infections, caving for fungal infections. There's loads of stuff. Something that's not on here that you should also ask about is if they had any sexual contacts. And if you suspect that there is an infection, you need to be a bit more specific. So you're asking a longer travel history, any infections and travel within the last 12 months, specifically where did they travel? Specific areas are at higher risk of certain infections. If you're traveling through the Middle East, you might be suspecting MERS if they present with respiratory symptoms. And this exposure to ill or deceased individuals, again, that's for respiratory infections and some of the more serious ones, which is like viral hemorrhagic fevers, which we'll talk about later. So, very helpfully, he tells you that he has headaches, a headache and body aches, which isn't going to change your differentials at all, to be honest. It's a very like generic presentation, but you have taken an excellent travel history and you've got some positives and negatives. So we've got that he's stayed in multiple places, tried to take some chemoprophylaxis in the form of doxycycline, usually to prevent malaria, but he hasn't taken it that well. He knows that he's been bitten by mosquitoes, but not animals. Went swimming, ate street food. So based on this kind of picture that we have here, what might you be suspecting in Albury here?
So we've got malaria.
That's probably going to be a top one at this point. Yeah, malaria is a great one. Can anyone think of any others that you might want to consider? That is not a problem. So just to give you like a kind of scoping idea of how this is what we would consider neglected tropical diseases spread across the world. It's pretty varied, and the specific area that they've traveled to might not give you the biggest hint on what they've got. In some cases, it can. So you might be able to see on that left map, India, there's regions that are quite specific to having malaria or dengue or chikungunya. So it might narrow down your differentials a bit, but you're going to have to do a lot more work than guess just based on where they've gone. something useful that you can say to patients or in scenarios where they're asking you to talk to a patient is direct them to government websites. One of them is like the Gov UK travel advice, which will notify people of any current disease outbreaks and health advice to those countries that they plan to visit. Another one here is Travel Health Pro, which if you've done Lective, then you might have already used. If you haven't, then you might be advised to use it. Okay, so these are a few that I think are relevant. Malaria, like you said, is probably a top differential at this point. Dengue, don't forget that. And there's a few others. Unfortunately, history taking will only get you so far with these infections because they disseminate quite quickly in the body and they can have poor tissue specificity, so they might not infect a specific site, leading to a specific focus of infection. Really, the mainstay is doing the correct investigations, which we'll get onto. When you're examining these patients, though, you can put together some clinical signs and symptoms to kind of create a syndrome. One of the easy ones to ask about and to look at in a patient is this idea of a migratory rash. That's basically a rash that either moves around or comes off and comes on. And what that might indicate is actual like larvae that are moving within the skin. Other things that are really common are like hepatosplenomegaly that can happen in multiple things, but it tends to happen in the more severe infections. So that might be a plasmodium malaria, for example. Another really common, well, not a common one, but something that you'd see and probably know what's going on is lymphedema. So if they've got a really, really massively swollen limb all over the limb, that might point to a filaria infection. What that is basically a parasite that goes into the lymph vessels and blocks them, so fluid can't flow properly, and then that limb will swell up. But just have a look at these later. I don't know if you'll find these massively helpful, but these are just some ideas that you can put together. Okay, so you do your examination and you notice that you poke his joint and it hurts a little bit. He looks a bit red in the face. Again, your clinical examinations are excellent. You know he's got a slightly big liver as well. And then you do your observations. Seems okay, except for his temperature, which is a bit high. So we're getting the picture that obviously something's happening. There's some sort of infection, but how are we going to localize the infection? How are you going to pick what investigations you want? So why don't we put some investigations to do, and I'll give you all of the normal ones like full blood counts and blood cultures and all of that. What could you do that's specific to an infection in a returning traveller?
So we have a blood film.
Really, really important for malaria. That's probably the most common one that you'll hear, but there are some like rapid diagnostic tests that look at the actual antigens from the infective agents. So these are the normal ones that you'll be doing on most of your patients. I think the ones that I want to point out to you are probably the full blood count. You're looking at how white cells and platelets react to this infection. Usually you want to see platelets going up because they're an acute phase, a positive acute phase reactant, meaning that if you've got inflammation, usually they'll go up. Some infections, though, can bring them down. And also, if you've got a person who's returned from abroad with fever and anemia, you're probably looking at malaria, and often it can be really severe malaria if that's the only thing that they presented with. If they come to a GP practice, you're probably going to send them to A&E. CRP I've just highlighted in red because it's not massively useful as a one-off measure. It's only really useful when you track it over a number of measurements and see is the picture that this patient is deteriorating or recovering. Cool. So these are the more specific ones. So someone mentioned blood films. So we have two types of blood films. There's the thick ones, which look at the blood generally and ask, is there parasite in this blood? Yes or no. And then once we've specified that there is, we can look at thin smear and look, what is the actual parasite given? And again, like I said, there are specific like serological tests, so looking at antibodies and antigens that relate to those antibodies to see if there's a specific condition that we can diagnose quickly, which there may well be. The leptospira rickettsial stuff is a little bit more rare. You might not see it at all. You will have seen PCRs. They're done for COVID. They're done for other viral infections too. So there are a couple more, but he hasn't presented with symptoms that would make us suspect these infections. If they've got gastrointestinal symptoms, then you can do stool cultures. Okay, so as we said, we don't know what's going on in this patient. A GP practice is not equipped to deal with this. You're going to send them to the hospital, ideally to A&E. So they do their first set of bloods, and they have a look. And what we've found is actually in their full blood count, everything's a bit low. The HB is low, white cell count's a bit low, platelets definitely low. LFT is a bit deranged. Everything else is okay for now. Just based on this, anybody have any comments or know what the picture is? I guess a more important question is are we happy that he hasn't got malaria?
So we have a comment saying thrombocytopenia indicating malaria or dengue.
Cool. So yes, based off what we just saw, right? Platelets can go low in specific infections. So what about this malarial film then? We've seen that it's negative. Are we happy to rule it out? Yes or no?
So we have no from Usman.
Excellent, right? It's an exam trap. You need to do at least 3 of them, ideally spaced 24 hours apart, can be spaced like 12 hours apart. Once you've done 3 of them, then and they're all negative, you can happily rule them out. But for the sake of time, we're not going to wait for that. We're going to do the rest of his results. And there we go. We can see that one of our antigen tests has turned up positive. Now, the dengue NS1 antigen is the most common antigen on the dengue virus. But what you'll see is that it's most specific in early infection. So once patients get fever, it's probably going to be positive for about a week, and then it will turn negative. And the reason that happens is because your body starts to produce antibodies and wipe out the antigen, at which point the dengue IgM would be more relevant. So a couple of these will be more related to the specific time points. If you've had a look at like hepatitis serology, that's also really specific to the time points. Same with HIV interpretations. Okay, so a short bit on malaria, just because it's probably the most common thing you'll be asked about. It's like a really simple parasite, but the way that it works is incredibly complex. It's got 2 different life cycles. And we as people tend to think that malaria wants to infect us. Actually, it doesn't. Mosquitoes are where malaria wants to be because that's where it sexually reproduces. It gets into the body in order to build a massive load of parasites and then go and infect loads and loads of mosquitoes. So what happens is you get bitten with a mosquito, they release some parasite, they go into your liver to build up a load, and then it's a game of getting out of the body as quickly as possible. That's why they enter the blood cells. And the reason that you get the complications associated with malaria, so that's like hepatic failure or cerebral malaria, is because the spleen would filter out any of the red blood cells that have the parasite in it. It can notice that it's deformed and not as elastic as normal. So basically, malaria forces the red blood cells to hide in other organs, which is just crazy to think about, that a parasite has that much control over your body. But even worse than that, or maybe even better, is the fact that somehow all of those parasites in your body will communicate to develop at exactly the same rate. And what that means is they all burst out of red blood cells at the same rate to infect more red blood cells. And that is why you get these patterns that you see in malaria. So the most important one to know about, because it's the most severe, is Plasmodium falciparum. And also equally as severe is the Knowlesi strain, which is a bit more recent. So either they will have daily fevers that spike up and down every time those parasites burst out of blood cells, or they can be a bit more irregular. But absolutely one to remember if you've got a patient with this unrelenting fever that goes on, goes off daily. Cool. And then this is just like not a helpful image, but you get the idea. The parasites look slightly different, and depending on what stage of their life cycle they're at, you can identify it. So when they're doing the thin smears, this is what they're looking for. This is important because the specific parasite will tell you how you treat it as well, but we will get onto that. Okay, so there are a few, so malaria obviously is a parasite, but there are some viruses that come from mosquitoes too. These are the more common ones. You do get cases of these in the UK, although they're not very common at all. So malaria, there's probably a few thousand in the UK every year from people that come back from abroad. Dengue, maybe 1,000. I think chikungunya, maybe 100. And the others, like 10 to 15, roughly. The reason that I think this is important is just to look for the severe complications, because they target their own type of cell, they lead to their own complications. So Zika, if you get it during pregnancy, it's pretty what's the word? Anyway, it affects the baby, right? It affects development, meaning that pretty much invariably you will have complications continuing with that pregnancy. Someone with long-term joint pain after a viral infection, it might be chikungunya. Dengue, usually it's fine and asymptomatic. Occasionally it can lead to shock and a viral hemorrhagic fever that we will talk about. So yeah, as we saw with Aubrey, in the first week to probably 2 weeks, they present almost the same. And you're not going to be able to tell heads or tails as to where this infection is coming from or what it's affecting. You might be able to tell with the complications, but hopefully you've caught it before then, because it might well be too late. This is just like to give you a mind break if you need it. The mosquitoes that transmit them are different. Anopheles is for malaria, Aedes is for all the other stuff. The reason they don't carry each other's diseases is because they have their own immune systems that don't let them happen. You can see they look a bit different, and actually they have different behavioral characteristics too. The Anopheles ones tend to be in rural areas and bite at the night. Aedes mosquitoes tend to be in urban areas and bite during the day. But that's just fun facts for you to tell patients if you so wish. So Aubrey, knowing all of this from his infectious disease teaching, is like, okay, you've diagnosed me with dengue, probably not going to do anything. It's probably going to go away by itself. So I'm going to go home. I've got like music to write or whatever, right? But then a few days later, he's back, and this time he's in A&E, and he's not in good shape. He's feeling a lot worse, and the A&E doctor has a look at him and sees this on his body. This is a rash, and I don't know if you guys have done them. Hopefully you have, because why don't you have a go at describing what you see within this rash?
So we have erythematous.
Probably like the biggest keyword, right? It is a very red rash, and it covers a lot of the body. And we can see that there are occasional white patches as well. So this is what we describe as a maculopapular rash. So in relation to dengue, often it appears on the trunk. this little image at the bottom is that tourniquet test, which I've never seen done before, but it's a test that people can do pretty easily. Essentially, what you're testing is, does this patient have fragile capillaries due to excessive inflammation or really low platelets? So what you'll do is either use a tourniquet or a blood pressure cuff, and you'll tie it to them, leave it there for 5 minutes. Ideally, it's a blood pressure cuff because you want it somewhere between their systolic and diastolic pressure. And then you take it off and then you count the number of petechia. If you can see that there's a lot, based on some cutoff that you want to use, you know that either you basically know something's going wrong, right? That they've got very few platelets or their capillaries are bursting and you want to know why. But here's the thing, right? His fever has started to settle, and his blood pressure has dropped. So, what do we think? I'll give you options to make it easier. So either you can send him home, or you can call the medreg, or you can just observe him in A&E for some more time. What do you think you should do?
So we've got medreg, please.
And stat, yes, please. So, another thing to note, actually. So if you remember right at the start of the case, he complained of like, or we saw that he had some flushing on his face. That's the like really, really early presentation of this rash. And what happens is as the fever drops, then this rash can suddenly get worse. And you can see that with some of the other observations that you do. Pruritus or itching is usually a sign that these patients are actually starting to recover. The reason that that can help is that if you're differentiating it from like scarlet fever or measles, usually when the rash is high, when the fever is high, the rash is also there. But in dengue, it's not like that. And this is what we'd call the critical phase of dengue. Essentially, what has happened is your body has produced antibodies and cytokines and a lot more than you probably need. So your capillaries start to become leaky. They leak out the fluid, but the actual blood cells stay in there, and then the blood becomes sticky and concentrated. When that flows around the body, obviously that can get stuck and cause organ dysfunction. Depending on where that fluid leaks into, it's going to cause ascites or pleural effusion. This is an uncommon complication. So if you remember, I was saying dengue, most of the cases are asymptomatic. At least 50% will be asymptomatic, which means you recover without anything at all. Of the like, let's say 40% that are symptomatic, maybe 5% of them will go to something like this. And it's called the critical phase because it can lead to further deteriorations, namely dengue shock, which is where your circulation isn't working anymore. You're going to need some kind of organ support or to be pumped with fluids, or worst case scenario, a viral hemorrhagic fever, which is essentially the same thing as what we saw before, but now you've also got coagulopathy, so you're just bleeding from loads of places and places that you don't want to be bleeding from. So there are a number of them. There are these 5 main ones. They're all RNA viruses, and they tend to come from animals or some kind of vector. The reason that they're high fatality is because patients will just switch like this, and once they have, it's really, really hard to get the immune system back into like normal shape. So that's why we ask the questions of, have you been in contact with anyone who's been ill, anyone in hospital, anyone dead or dying? Because those body fluids can still contain the virus, which can transfer. Again, as we can see, the early presentation, super non-specific, not going to help you a bunch unless you're like really switched on. Late presentation, you'll notice, might be too late. You're going to need to call a lot of people to get this sorted. Okay. The key takeaway on managing dengue is that it's just supportive, right? You're supporting the organ to get the immune response to be normal again. So you're going to give them fluids, you're going to give them symptomatic management, monitor their organs. If those organs get worse, you step up get more senior support, send them to ICU if needed. They might need transfusions, they might need inotropes. The reason that do I need to point this out? No, probably not. Okay, so like I was saying, basically you just need to track their symptoms. One thing that you might think, because it's an immune response that's basically going haywire, maybe try steroids. Don't try steroids. It doesn't help them at all. That's what studies have shown. Giving steroids can worsen their condition. So you just let the body recover as it can, and hope for the best, really. Malaria, again, is the most common one. You're going to be giving, depending on the type of malaria, if it's falciparum, then you're going to give this artemisinin-based therapy. It works really, really well for malaria, and it will work really well for the other types of malaria that are non-falciparum as well. But you don't give them, firstly, because it's far more expensive than these other treatments, and secondly, because they can develop resistance to it. So the reason that you can't give chloroquine for falciparum malaria is because it's just completely resistant at this point. It's not useful when you give it to them. So you reserve it for the severe cases. If your malaria is getting worse, so you have a high parasite load, I think it's over 2% in the blood, then you're going to give it to them IV. You can give quinines as well, but they tend to cause, I think it's QT prolongation, so you'll need to cardiac monitor them. So these red flags that I've included is just for step up, or your treatment is not working. Consider something else. Okay, so luckily we have made it to the other side with Aubrey. He is starting to feel better, look better. He's ready to go home. So he goes home and we get the summary of all of these lovely infections to learn. I guess these are like kind of the one-liners for you to remember. So particularly if they say breakbone fever in dengue, in an infection, you're thinking dengue. The headache is usually behind the eyes, probably because a lot of fluid builds up there for whatever reason, puts pressure on the eyes, and then it causes that retroorbital headache. And then you can look at these patterns in the blood. Again, like we said, that there are some long-term complications associated with these conditions, which the vast majority of patients aren't going to get, but it's something to look out for, right? Yes, public health. Okay, so someone had mentioned it earlier, but some of these conditions will be notifiable. It's a legal requirement, so that there is some kind of surveillance for these conditions. They can obviously be really, really severe. And if you look at the actual website, it will tell you how quickly you need to report it, and it will usually tell you how to report it as well. Most of the time, you're not going to isolate the patient. There may be a rare occasion where you do have to. And if it's a really severe or rare case, you might discuss it with RIPL, which is a laboratory for rare and imported pathogens. So notifiable diseases, I've covered most of this. Like I think we tend to forget just how important some of these things are. Like notifiable diseases first started, I think, when there was the cholera outbreak, or maybe around like the smallpox era. And that led to them being able to actually control the condition. Obviously, a lot of people died, right? The OGs from the Middle Ages will remember, right? The Black Death wiped out probably a third of Europe. So these conditions can spread massively, really quickly, wipe out like economies, agriculture, wildlife, all of that. So important to stay on top of. If you're a GP, you'll basically just be filling in an online form. You'll send it off to UKHSA, who will do whatever they need to do. Some of them require same day or urgent notifiable notification. So that's like if you've got a meningococcal sepsis, rabies, or one of these fevers. Hopefully you never see those. And then if you're actually working in conjunction with someone with VHF, you're going to need to take a lot of protection, enhanced PPE, basically, and isolate the patient. Okay, last take-home message is that, as you will have seen, for most of the conditions, that aren't malaria. We don't have specific treatment, which is why we rely on prevention. Even in the case of malaria, things can go haywire when you do treat them. So in the countries where this is prevalent, the most important things that they do is try and mitigate things that could increase the risk. So that's like removing stagnant water, that's where mosquitoes will breed, putting insecticide treated nets around beds, and chemoprophylaxis if you're traveling. They have tried to roll out a couple of vaccines that haven't been massively effective. The first one that they rolled out for malaria lost probably 90% of its efficacy within a year and a half. There's been a newer one since then that's a bit more effective. But this is why prevention is like the absolute mainstay in these conditions. That I think that's everything that I had to talk about. If you've got a question, just write it in the chat and I'll respond while the next person is presenting. But thanks so much for your time.
Thank you, Caven. Really, really interesting slides. So we're going to do our final part of the session and series. So high yield antimicrobials and common causative organisms that you need to know for your exams. So Usman, if you want to share your slides.
Can you see this?
Yep.
Yeah. All right. So, commendations to everyone for sticking through. I know it's a lot of information. So I just wanted to add this section because it sort of like wraps everything up and it's high yield as well. So pertinent for the upcoming MLA / progress test for the year 3s and year 4s. So let's jump right into it. So what I'm going to do is I'm going to say the antibiotic / antimicrobial, and just to make it interactive, somebody can tell me what is first line for and bonus points for the bug that causes that particular infection. So if we want to start with amoxicillin, let's see if I can. Yeah, I don't think I can see the chat. So Lydia, do you want to, if anyone mentions anything in the chat, do you want to?
Yep, I'll read out if anyone mentions anything.
Yep. Think ENT. What can a mox be used for?
So we have from Himesh, Lyme disease in pregnancy.
Yep, right. That's right. Think something that's very common, happens in children a lot. ENT.
Otitis media.
Perfect. Otitis media. Bonus points for bug. Might be a bit difficult, but I'll give the answer. Strep pneumonia. Fluclox. Think dermatology.
Cellulitis and skin
Perfect.
infections.
Excellent. And most likely causative organism?
Staph aureus.
Excellent. Tetracyclines, lamicycline and doxycycline. What are we thinking? And also
Lyme disease.
Lyme disease, yep, that's one of them. How about lamicycline? Think about dermatology and teenagers.
Acne.
Right. And how about an STI?
We've got a comment for gonorrhea.
Not gonorrhea, the other one begins with a C. Chlamydia. So we mentioned acne, Lyme, chlamydia, and causative agent of acne most likely is Propionibacterium acnes. Lyme disease, we covered it before, is the Burgdorferi, and chlamydia is Chlamydia trachomatis. Yep. Comox, 3 indications, first line. What are we thinking? So these are more severe infections. Comox is quite broad spectrum.
Pneumonia.
Pneumonia, yep, that's one of them as well. Severe pneumonia. I'm going to get to pneumonia.
Human
Because-
bite.
Human bites, excellent. That includes cat and dog bites. How about think about elderly patient who's come in, has abdo pain and has diarrhea and some blood as well. A lot of elderly patients have diverticular disease, acute diverticulitis. And think about breast infections. For those UFOs who've done their, I don't know if you've done your breast week yet. What are we thinking? Mastitis, non-lactation mastitis. So we've got acute diverticulitis, non-lactation mastitis, and human cat.
Sorry,
dog
we've
bite.
got a comment about abscess. So I was just interested. Do you know
Mhm.
what you would use in a breast abscess, or would it be drainage? I'm not
Yeah,
too sure.
I believe it would be drainage. Generally with abscess it is drainage. Yep. And then antibiotics. Probably
Would you cover
Comox.
with Comox though?
Yeah, I imagine so. Local policy, check EOLAS. Right. So this was a bit difficult. So gram-negative, so E. coli, most common causative agent for non-lactation mastitis. Several agents, several organisms rather, Staph aureus, Enterococci, and anaerobes, and some weird and wacky ones for human, cat, and dog bites, as you can imagine. But Staph aureus and strep species. Phenoxymethyl penicillin or PenV, we had this before as well, but 2 indications, 3 actually. We had this before too. I didn't write it down, but we did have it before. Scarlet fever was one of them. And scarlet fever is caused by group A strep.
So we've got tonsillitis and scarlet fever and strep.
Excellent, excellent, excellent. Yep. Tonsillitis, acute sinusitis as well. Scarlet fever is also, scarlet fever is caused by group A strep, as aforementioned, and acute sinusitis. Though for sinusitis, of course, you want to be aware that it's primarily viral, and bacterial infections tend to be strep pneumonia. Pneumycin, gentamicin, and ciprofloxacin. Think ENT again. Pneumycin and gentamicin are aminoglycosides.
Otitis externa.
Excellent. Most common organisms are Pseudomonas aeruginosa and Staph aureus. So, yep, those are some very, very common antibiotics, and the first lines of indications. Got some more antimicrobials. This one should be fairly straightforward. Nitrofurantoin and trimethoprim. What are we thinking? Think urology.
Yeah, so we've got UTI.
Excellent. Bonus points for 2 most common causative organisms.
E. coli. We've got
Mhm.
Neisseria as well.
Yep, Neisseria is one of them, but more common than that, E. coli, and Klebsiella pneumonia. Cefalexin. So on the same sort of, in the same vein as nitrofurantoin and trimethoprim, think about infections that track more sort of proximally, more severe.
Pyelonephritis.
Great. Yep, pyelonephritis. And same thing, E. coli, Klebsiella. Ceftriaxone. This was mentioned before as well for 2 particular indications. What can we give Kev for? First line. Because we can give Kev for many things, but first line.
We've got gonorrhea and then also meningococcal septicemia.
Yep. And something that was mentioned before as well was Lyme disease. That's disseminated. So disseminated Lyme disease and Neisseria gonorrhea. And the dose, this is high yield as well, 1 gram intramuscular stat for gonorrhea. Metronidazole. Think about like, a woman who comes in and has a lot of vaginal discharge.
So we've got BV.
BV, good. And that's caused by anaerobes, mainly Gardnerella vaginalis. Intramuscular benzathine penicillin, one indication, one very high yield indication. And I'll give you a clue, it's an STI.
So we have GP meningococcal septicemia, which I think is right. I think they can give benzyl penicillin in the community, I believe, but they can also give the other one, which I don't want to give away.
Yep.
And then we've got syphilis as well.
That's the one I had, syphilis. Yep. Yeah, but you're right, you do give that in the community for children. But yep, syphilis, so I said STI, and that's caused by treponema. Acyclovir, give me 3 indications for that. And we had some of these before as well.
Herpes.
Yep, gentle herpes is one of them.
Encephalitis as well.
And one that's caused by varicella.
So you've got HSV, shingles.
Yep, excellent. Shingles, cold sores, genital herpes. Shingles, VZV, cold sores, HSV1, and genital herpes, HSV2. Sometimes HSV2 can cause cold sores, sometimes HSV1 can cause genital herpes, but mainly 1 causes cold sores and 2 causes genital herpes. And this is what for the person who mentioned pneumonia, so this is for combined courses. So amoxicillin, doxin, chlorith, that was for CAP. Most common causative organisms here, strep pneumonia, Haemophilus influenza, Moxellus catarrhalis rather, Legionella, Mycoplasma. They're the most common organisms. Amoxicillin, chlorith, and omeprazole. What's that for? Think GI.
We've got Helicobacter H. pylori infection.
That's right. H. pylori. Well done. IM-Kef, doxy, and metronidazole. So we had some of these before. It's a gynecological presentation, usually more severe. Can be asymptomatic as well, though, and can cause infertility. Any thoughts?
So we've got quite a few for PID.
PID. That's right. And yeah, that's chlamydia, gonorrhea, and mycoplasma. Yep. Benzyl penicillin. This is what we discussed before, and Kef in the hospital. So we mentioned this already, bacterial meningitis. But what are the most common causative agents? Organisms. I keep saying agents, sorry, I mean organism. I think someone mentioned it before as well.
So you've got Streptococcus.
Yep. Nice area as well. This one's standard, rifampicin, isoniazid, presinomide, and ethambutol. And
So we've got
this one,
TB.
yeah, TB.
Yeah.
So for this one, which ones do you give for the first 2 months? Which ones do you give for 4 months? A bit of active recall.
So rifampicin and isoniazid we've got for 4.
Hmm. I think it's the other way around. Believe it's pyrazinamide and ethambutol for oh yeah, so first 2 months is rifampicin and isoniazid, yeah, so yeah, that's right, and then the subsequent 4 months is pyrazinamide and ethambutol. Yep. This was covered literally in the last one. I believe these are called artemisinin, but what are we thinking?
Yeah, so we've got malaria.
Yep, malaria. And K-Ban kindly covered it before, so Plasmodium falciparum, that's the sort of main one, and that's the more severe one that we're considering. Nearly done. I believe this is the last one. Intravenous metronidazole and oral vancomycin. What are we thinking?
So we've got severe C. diff.
That's right. Life-threatening C. diff. And first line is oral vancomycin. Second line is oral fidaxomicin. But yeah, severe life-threatening, you give IV metronidazole and oral vancomycin. And I believe that concludes my section. So I'm going to give it back to Lydia.
Yep. So that's the end of our infectious disease teaching series. So thank you everyone for joining, and also thank you to everyone that taught. It's been really interesting to listen to as well. So if everyone could just please fill in the feedback forms, and that way I know to email you the slides. And also please follow our Instagram, which is Infectious Diseases. And thank you everyone for interacting as well. It's been really